I'll just introduce myself again. My name is Jen Pinkstone and I am a physiotherapist. I work at Southmead Hospital, work closely with Mr. Hashim, Mr. Drake, Mr. Madhu. And Mr. Hashim has asked me to talk with you today a bit about the role of the physiotherapist in the management of female urinary incontinence with a focus on stress urinary incontinence. Okay, so my aim today is to bring to you the most efficacious treatment options, and we'll kind of kick off. I'm going to just bash through this quite quickly. We've got multiple well-powered, methodologically sound epidemiological studies to tell us that 30 to 60% of the female adult population suffers with urinary incontinence, and that number increases with advancing years. Why does this matter? Well, we know that the physical, the social and the psychological effects of urinary incontinence are profound, embarrassing, and they affect quality of life. And there's a link between suffering with urinary incontinence and developing secondary health-related comorbidities. So the cost is also significant financially, and it's not a new problem. We're all here today to help to manage this problem. So what is the significance for me as a physiotherapist? We have been able to prove time and time again that physiotherapy, and specifically pelvic floor muscle training, is a safe and effective treatment modality to help with urinary incontinence, and specifically with stress urinary incontinence. We've got level 1 grade A evidence in the form of NICE guidelines and Cochrane reviews and other systematic reviews that tell us that it should be offered as first-line treatment in the conservative management of our patients, really. I want to just draw your attention, just to start off with, to this review that was done by Chantal Dumoulin and her team back in 2014. This was published in the Cochrane Library, and it looked at 18 randomized control trials with over 1,000 women who had mixed urinary incontinence, stress urinary incontinence, or urge urinary incontinence. And it compared the effect of pelvic floor muscle training with no treatment or sham or placebo. And essentially, where the primary outcome was cure, we were able to demonstrate that 56% of the women who were participating in pelvic floor muscle training were cured from their symptoms, which is really positive results. And in addition, we also noticed that there was improved quality of life and fewer episodes of incontinence. We noted that the effect size was greater in the patients who specifically suffered with stress urinary incontinence, and that we seemed to have better effects when there was more supervision. And these are really positive results for physiotherapists, because actually in the physiotherapy world, there's a real dearth of really good quality research to suggest that our specific interventions can make such profound differences. So, for example, with back pain, we know that exercise works with back pain, but we wouldn't be able to know what type of exercise specifically can help to make people's quality of life better. So I'm not going to go over what Marcus has already covered already from a diagnostic point of view, but in our history, we would both subjectively and objectively try to comply with the ICI recommendations, as well as both local and national standards when it comes to our assessment as a group of physiotherapists. So you can see I've kind of demonstrated here what we would cover in our subjective examination, and the consenting patient would then go on to have an objective examination, which involves a vaginal examination, and the mainstay of that would involve a pelvic floor muscle assessment. And I want to just talk to you a little bit more about that today, if possible. Before I go on to jumping into pelvic floor muscle assessment, I just wanted to remind ourselves of some of the theoretical rationale behind using intensive pelvic floor muscle training to help with stress incontinence. The idea is that as we build up the structural support within the pelvis, we can permanently lift the levator plate to a higher position within the pelvis, and the process of achieving hypertrophy in the levator ani muscles kind of bolsters and supports the bladder neck and uretrovesical structures such that when there is an increase in intra-abdominal pressure, there is less descent there. So understanding what our pelvic floor muscles look like at baseline is really important for our treatment, especially when we're trying to provide a specific pelvic floor muscle training program. Does that make sense? So when it comes to pelvic floor muscle assessment, there's been much discussion over the years regarding which is the most helpful tool to use, whether that be perinometry, whether that be EMG, whether that be a digital examination, whether that be the use of ultrasound. And there's upward of 25 different digital processes or scales that are documented in the literature. And the reason for that is because there's no real, one specific tool that can tell us or measure both compression and elevation of the levator ani musculature. So as such, it is questionable as to whether a digital examination can truly tell us whether there is a significant change in pelvic floor muscle strength unless there's really significant changes or differences in force, really. So the Carrie Bow back in 2005 did, however, suggest that for the physiotherapist, digital examination is a really helpful tool to be able to understand what is going on with the pelvic floor and also to be able to provide immediate feedback to the patient. And indeed, it's probably the bedrock for the physio who's working in the urogyne clinic or in the physio clinic. And it is what I use, absolutely. We know that up to a third of women will be unable to isolate their pelvic floor muscles when you prompt them. And actually, in one study, up to 25% of women actually performed a Valsalva maneuver when we asked them to work their pelvic floor muscles. Now, a correct pelvic floor contraction is generally characterized by cephalic and an anterior movement of those muscular structures. And what we've been able to identify in more recent years is that a posterior or a combined cue seems to be more effective in eliciting that response compared with just an anterior prompt. So in a clinical setting, I will more often than not ask my patients to tighten their pelvic floor as if they were stopping wind from escaping, as opposed to, say, stopping the stream of urine. We've found that seems to be more effective in eliciting that response. So I would encourage you to use that if you're not already in your practice. But because isolating the pelvic floor muscles is sometimes a complex process, we need to have different, options at our hands, really, and option hints and tips, both verbal prompts and physical methods to help our patients. One of the processes that has really taken off in recent years is the use of ultrasound, both as a diagnostic tool. This is in the physio clinic specifically, both from a diagnostic point of view in terms of identifying levator avulsion, structural abnormalities, but also as a tool to be able to provide feedback for our patients about when they're working their pelvic floor muscles correctly. So although it's not something that I use in my clinical practice, there will certainly be therapists out there that do use ultrasound. Another quite interesting modality that hasn't really been extensively explored in the literature yet is the use of breathing in pelvic floor muscle education and in my pelvic floor muscle assessment. So in that sense, what we're trying to do is think of the pelvic floor as part of the larger abdominal canister, and to consider the role of breathing in regulating changes in intra-abdominal pressure. So where, for example, patients might struggle to recruit their pelvic floor, there are certainly therapists out there who will look at breathing patterns and teach specifically diaphragmatic breathing to see if it makes it easier for patients to work their pelvic floor. So for example, I might get my patient to place their one hand on their apices of their lungs and one hand on their upper abdomen and ask them to gently breathe into their upper abdomen without performing a Valsalva, and ask them to contract their pelvic floor on the out breath. And we've found that that's quite a helpful prompt in kind of replicating this correct contraction, as it were. Certainly there's no real consensus or data around this, and it's an area that is being looked into and being researched further. So this picture was a picture that was produced by a physio colleague, Maeve Whelan, who's really taught extensively on digital assessment of the pelvic floor. She's taught at ICS events in the past. I've borrowed some of these pictures from her. And in my clinical practice, I will use a single digit to move throughout the pelvic diaphragm to identify feel of the muscles, end feel of the muscles, whether there is pain, feeling for symmetry, feeling for give, and getting a response from the patient with regard how that palpation promotes or provokes any symptoms, as it were. Having started our vaginal assessment, we then go on to grade pelvic floor muscle strength. Now, this is the modified Oxford grading score. Is this a score that you guys would use or have seen before in clinic? No? Okay. So this tool is a tool that was developed by Jo Laycock in the 1990s. She's a physiotherapist, and it's a validated score that allows us to grade pelvic floor muscle strength, so that we can then go on to prescribe a specific exercise program for patients. And it's a validated score, as I said, so this is used almost exclusively in the UK to grade pelvic floor muscle strength. And I know Madhu would certainly use it in his urogynecology clinic. You can see right here, a 0 out of 5 would be characterized by no contraction at all of the levator ani musculature. A 1 would be a flicker of a contraction. 2 would be characterized by a squeeze but without a lift of the levator ani. 4 out of 5 would be characterized by a contraction against resistance, so we would come onto the pelvic floor musculature, provide some resistance, and 5 would be a very strong pelvic floor. I don't give out 5 out of 5 very often. Having identified the strength of the pelvic floor, we will incorporate that into a wider tool that was again also developed by Jo Laycock, but in the early 2000s. And so this acronym, the PERFECT acronym, or the PERFECT scheme, is kind of the basis for our pelvic floor muscle prescription, as it were. So power represents here the Oxford score, the strength of the maximal voluntary contraction. The E and the R represent how many slower and longer contractions the patient can, or how many seconds, the patient could hold for out of 10 seconds. And the R would represent how many times the patient could reproduce that 10-second hold with a 4-second gap in between. So this tool is giving us a fuller picture of pelvic floor muscle function. The F represents the fast contractions of the pelvic floor. So we know that the pelvic floor is made up of 70% slow twitch fibers and 30% fast twitch fibers. So again, it's just broadening our understanding of how that muscle can perform. And the ECT at the end here kind of reminds us that our training program needs to be specific for each individual patient. The NICE guidelines would suggest 8 contractions 3 times a day, but then that's not always possible for every patient. So it's just thinking, how can we make this specific for the patients? when we have less of a consensus with regards what is the optimal training program for the patient who's performing pelvic floor muscle training, okay? And this seems to be because every study that looks at pelvic floor muscle training uses different outcomes, it uses different duration of contractions, it uses different types of exercise programs. And so it's been very difficult to compare that. And as I just said a minute ago, the NICE guidelines that were produced in 2013 recommend 8 contractions 3 times a day over a 3-month period, but that actually seemed to be the lowest number of recommended pelvic floor contractions in those studies. And you know, I think it's difficult for us to say that every patient obviously should be doing the same thing. Indeed, this Cochrane review that was done by Hay-Smith et al. Looked at 21 trials and included over 1,400 patients, and they tried to compare the effect of training type and duration, and what they were inconclusive in saying that, yeah?
Usually, how long does it take to show effectiveness? How long does the
Absolutely. I think, yeah, so that's a great question. How long does it take for the training effect to take size? Or to take place? I think it's very variable. The recommended amount is 3 months, but there will certainly be some patients, if they're starting from 0 or 1 out of 5, then it's going to take longer. And again, what we don't necessarily have is the ability to say that a 3 out of, you know, there will be patients out there who have a 3 out of 5 on the Oxford score and are continent. You know, they don't have any problems with stress incontinence. So that's why a supervised and individualized training program is really, really important.
Is it a lifelong commitment to this program, or
good question.
After some time it will show effectiveness over the long term?
Again, really good question. So what we have is evidence to suggest that the hard bit is building the muscle strength. So that hypertrophy and that building up of the structural support within the pelvis can take 3 to 6 months. But it's then easier to maintain the pelvic floor it's easier to maintain the pelvic floor strength, but we would encourage patients to be doing their pelvic floor exercises once a day. And I'll come on to talk a little bit about why this is a challenge for us in just 2 seconds. But yeah, essentially, yeah, go on.
No, I just want to ask how
yes.
frequently you need to follow up on
this. Yes, absolutely. So the results of this study here were that they were unable to make any conclusive recommendations with regard what's the best type of exercise regime to do, but what they found was that increased supervision and supervision was more effective and had better results. So the more frequently you followed your patients up, the better the effect size really. Certainly within that period of supervised training really. Any other questions? Okay. So what do I do in my clinical practice? I would kind of kick off by educating the patient with regards normal pelvic floor muscle function and normal urogyne function, often using models and pictures to help them at a patient appropriate level understand what is going on, like what the problem is. And then I would verbally teach a pelvic floor muscle contraction before I would assess them. I would then go on to assess the patient and to supervise that contraction with them, carrying out the Oxford grading score, using the Oxford grading score and using the perfect scheme. And at that stage, I can then prescribe an exercise program that is specific for that patient. So there is no point in me trying to get a woman to start exercising her pelvic floor when she's at the traffic lights in the car if she can't contract her pelvic floor well when she's lying down. Equally, if a patient is symptomatic, if they're stress incontinent when they're up and moving, I need to incorporate my training program into that functional activity. So it's really important that it's a specific exercise program for that patient. Now, on top of that baseline pelvic floor muscle training, we would also encourage patients to use something called the knack maneuver, which is essentially a pre-contraction of the pelvic floor before there is an increase in intra-abdominal pressure. So before a patient lifts, coughs, sneezes, we would encourage them to try and coordinate their pelvic floor muscle contraction to bolster their bladder neck, bolster their the uretrovesical structures. And that process has been demonstrated to reduce stress incontinence in a deep cough by up to 70% and in a medium cough by up to 90%. So again, it's that higher level of function that we're trying to incorporate back into the rehabilitation process. Having provided an exercise program that's specific to the patient, we'll then go on to document it and, like I've just kind of touched on, to try and follow our patients up regularly. Now, in a busy NHS clinic, which is where I work, it's very difficult to follow our patients up on a weekly basis. And if the patient understands what they're doing, often we will follow them up at later periods, 2 weeks, 3 weeks down the line, if they're feeling in control. But equally, we will try to offer more frequent appointments if we deem that that is necessary to encourage compliance and adherence. You're probably already thinking this. So our greatest predictor of success is adherence. And one of our greatest challenges is adherence. You know, there's a really great piece of work that was came out of an event that happened just before ICS in Glasgow in 2011, where a group of MDT members led by Chantal Dumoulin came together to explore the barriers behind pelvic floor muscle adherence. And I'm not going to go into all the details of that study today, but essentially, in one of the surveys that they sent out, when they asked the clinicians, why do you think your patients are not adhering with their pelvic floor muscle programs, both in the short term and the long term, the response from the clinicians was, short term, you know, they weren't motivated, and in the long term, they just forgot. Whereas when they asked the patients, why do you think you're not adhering? It was because they didn't understand that we've got this great scientific evidence to tell us that pelvic floor muscle strength training actually works. Poor understanding of the benefits. So I think the clinical application there is that in our clinics, if we're referring to physio, and as a physio, we need to be exploring that with our patients and really conveying the great results that we have. And if you're doubtful at all you've got to do is ask my colleagues here, and they'll be able to tell you that we have great results with our patients. Saying that, there are of course modalities that have been investigated extensively over the years, because pelvic floor muscle adherence is difficult, because women can sometimes struggle to isolate their pelvic floor, because sometimes they can't isolate their pelvic floor at all because of a structural deficit. And so things like the biofeedback, the vaginal cones, and the electrical stimulation, I'm not going to go into in great depth today, but they've been, there are good quality Cochrane reviews that have investigated these, and essentially the results are it doesn't seem to be that any of those interventions are any more effective in helping to retrain the pelvic floor musculature when compared with pelvic floor muscle training. The evidence doesn't seem to be anywhere near as robust, and the results not as promising. However, they could be considered if the patient is really unable to recruit their pelvic floor at all. And as such, the NICE guidelines do recommend that they could be considered. But the bedrock for the physio working to try and manage female urinary incontinence should absolutely be start with supervised pelvic floor muscle training. Okay?
Do you use those things in your clinic?
Yeah, absolutely, because I don't want to chuck the baby out with the bathwater, so to say. I think the evidence would suggest that if your pelvic floor is a 0 or a 1 on the Oxford scale, then the use of electrical stimulation can be efficacious, can get you up to almost having an awareness of what a correct pelvic floor muscle contraction feels like, proprioceptively, what it feels like, And at that stage, you can then train the muscles. They can train the muscles. Equally, biofeedback can be an encouraging tool to use for patients to see progress in their treatment. So, for example, there is a product in the UK that is used extensively called the LV. And the LV is a little probe that is inserted vaginally, and it connects to your phone via Bluetooth. And when you squeeze your pelvic floor, there's a little ball that jumps up. So you know that you're working your pelvic floor correctly on your phone. Yeah.
Makes it more fun.
Makes it more fun. And then they give you a training program based on what's happening in your levator ani muscles. Now, they haven't been able to, that contraction doesn't just isolate the levator ani musculature. So you have to have a correct pelvic floor muscle contraction, which is why our role is important. We can teach that, but then biofeedback can be a helpful tool to help with, motivate and encourage our patients with compliance.
Because I think they would tend to be very tight.
The name of the product, that one is called an LV. Matt here has told me that he is aware of other products on the market that are available that do the same sort of thing.
Just LV.
ELVIE. ELVIE. I heard that it was, I believe it was designed by one of the head engineers at Dyson. So it's a really user-friendly product, super easy to use, and patients like that. I'm not here to promote any one product in particular, but I know that I have had patients who found that beneficial.
No, but that sounds really like,
Yeah.
there's a game or something where you can gain points or whatever.
Yeah,
People do it.
absolutely, absolutely.
I would
Yeah.
Great today.
So
Better than yesterday.
yeah, absolutely. And I think what they actually do in a lot of these programs is they are able to modify the program so that when the patient achieves a certain level, they then introduce harder tasks. So I've just talked about slow and fast contractions today, but often we will use submaximal contractions as well, and to optimize outcome. So a thorough individual assessment for patients. In a clinic, more often than not, it will be a digital assessment to give feedback, encouraging persistence with a pelvic floor muscle training, including the knack maneuver, following up our patients, and then encouraging our patients to continue independently with their pelvic floor muscle training. 10 quick, 10 slow, ideally once a day for the rest of their lives. Once a day. That's what we would recommend. Any other questions? Yeah.
When we decide to do conservative management?
Yes.
When the surgery failed or no?
Yeah, great question. So that was, when do we decide to use conservative management or surgical options? This is a physio's opinion on this, and that's what I'm going to give you, but I think we should absolutely be talking to the patient about what their expectations and beliefs are, first of all. So if they are absolutely adamant that they want surgery, sometimes it would be difficult to convince them otherwise, but we should be starting with conservative measures. Now, I've just brought to you today one option from a conservative management, pelvic floor muscle training, but Marcus and the team would use many more options, things like the pharmacological management, behavioral interventions such as bladder training and bladder education. These all play a massive part in managing urinary incontinence, and we would certainly encourage the use of them as first-line treatment, and if those measures fail, then we would proceed to considering more invasive options. Is that reasonable?
Right.
Yeah.
All the complex cases, send them to the gym.
We can talk about pelvic floor muscle training more. I'm
Yeah.
more than happy to talk about that with you, but
And I
hopefully.
think
On the hands-on part, that's fine. Good.
I think the physio are very good at localizing the muscle, which are actually quite useful on the cadavers as well. And Jenny can also show you what she feels for when we're operating. What she does, what she feels for. There's always, easy to say, oh, this muscle is there. Well, actually, the surface anatomy is very important. So she can show you where all the muscles are when you're doing the cadavers and what she feels for. Good. Any other questions before? I'm sure everyone wants to operate now and
Yeah.
get something, get their hands dirty.
Yeah, one more question.
Yeah.
Yeah, we're used to describe as well the relaxation.
Yes.
Not only the contraction, but also the relaxation.
Yes.
We don't use the Oxford score, but it's quite similar. We
Yeah.
describe it as non-existent, weak, moderate,
Yeah.
strong, normal.
Yeah.
But we also describe the relaxation.
Absolutely. And I think that's really important. I've kind of gone through this without having my notes to refer to directly. Pelvic floor relaxation is as important as pelvic floor contraction. Levator lift and levator dropping is really crucial. If a muscle is continually contracted, it can often become hypertonic and weak and ineffective. And this is a concept that we've really struggled to be able to give patients definitive feedback about, because we haven't really got any data on normative values yet. I've emailed Carrie Bowe, who is the professor and investigating a lot of this stuff, and she said herself, a lot of physios are talking about this concept of pelvic floor relaxation, but it's very much theoretical at this stage. Clinically, I think the important thing is, as we palpate for a levator lift, we should also be able to feel the patient let go. And that's what we're looking for. The patient would lift for a long, slow contraction and let go after 10 seconds. And when they do their fast contractions, it's a lift and a let go. Lift and a let go. Quickly.
Perfect.
Yeah.
Thank you very much indeed. So the real thing here about physiotherapy is this really requires belief. So this is where we have to have Jen, basically. We have to have somebody that's extremely approachable, very open, believes in it and conveys this belief, keeps up to date and allows appropriate amounts of time. It is not going to happen in a routine surgical clinic. We send them to Jen, so it happens. Interestingly, you hardly ever give a 5 out of 5. If you ever met a bloke with a 5 out of 5, you'd probably have to go to A&E with your finger to be reattached or something. And we haven't really mentioned men.
No, we haven't today, no.
But to be honest, I think the men, it's less likely to succeed, isn't it? Because that was shown by the men after prostate surgery study. Men are not going to be so delighted to meet Jen and say, right, I will now do a digital examination, which will help you to understand your pelvic floor. The men are probably more reticent. Is that fair to say?
It's interesting, Marcus. I think the men that end up in our clinic are really motivated because they're really disabled by their incontinence. So just this week, I met a chap whose mood was low and he was feeling rubbish, and he wanted to do anything to see if he could improve. And so when I assessed his pelvic floor, it was absolutely weak. And I've given him a supervised training program, and I will see him back, and we can, it's a muscle we can train that, and that will potentially improve that chap's symptoms.
You need to do a study.
We do.
There you go.
We've got lots of research to do.
Yeah, so this is absolutely fundamental. We do the conservative first. The other thing I would say is it might not be enough by itself, but it might be. Even if it's not, surgery has a better chance of success. Please do your pelvic floor exercises and believe in them is a crucial part of our input. So our concluding remark is conservative comes first. Failed conservative, you're then moving on to intervention, and physiotherapy is the bedrock of conservative intervention.